troubleshoot if we still have. So again, thank you everyone for joining us for this session. And we have the extreme pleasure and honor of having two of the speakers from CDC here. And I definitely want to thank Dr. Kara Jacobs-Slivka, who was with us last time, that we all thoroughly enjoyed during our last year's summit. About COVID-19 updates and everything around it. It was so much informative, and I think Dr. Slivka Jacobs, volunteer, Heather and Bola here from CDC, but thank you very much. And so Heather Jones, DNP from CDC, is a nurse practitioner and a nurse consultant at CDC's National Center for Emerging and Zoonotic Infectious Diseases, Division of Healthcare Quality with the Prevention and Response Branch, and works with Dr. Bola as part of long-term care team. Dr. Jones works on numerous projects focusing on enhancing and improving infection control measures in congregate setting. And so we are very thankful for that, Dr. Jones and Dr. Bola Ogundimu. I'm sorry if I butchered that. Is again from CDC. She's a nurse infection preventionist and health scientist at CDC's NCEZID, as Dr. Jones, and Division of Healthcare Quality Promotion, and works with Dr. Jones. Dr. Bola's role, she provides consultation and technical assistance for implementation of infection prevention and control strategies in long-term care setting, in collaboration with state and local health departments throughout U.S. And again, I repeat myself, we are so much very thankful for you to be here and share some of this information. Please take it away, Dr. Jones.
Perfect. Thank you, Raj. I just want to confirm that you can see my slides.
Yes.
Perfect. All right. Thank you, everyone, for allowing us this opportunity to speak to you today. We're going to use this time to kind of talk through some of the experiences that we've seen and heard about during COVID-19 in the nursing homes, mainly from an infection prevention and control standpoint. So we do not have any speaker disclosures, and the content of the presentation reflects our own opinion and does not necessarily reflect the official position of CDC. So our objectives today are going to go through some of the lessons learned prior to the pandemic, during the pandemic, and then to discuss how lessons learned can be used to develop opportunities for change in infection prevention and control moving forward. We're also going to review some of the recommended long-term care IPC practices. And first, I'd like to start by expressing my gratitude to all of the nursing home staff for their ongoing dedication and commitment to the residents and families. I'd also like to thank all of you for the hard work that you have done throughout this pandemic and continue to do, for your willingness to rapidly familiarize yourself with new and changing guidance, and for the work that you continue to do even in the face of unknown and changing conditions. We here at CDC have learned so much when we receive feedback and questions about how guidance and our IPC practices are being implemented and the successes and challenges that come along with that. So first, I want to talk a little bit about before the pandemic. So in 1987, the Nursing Home Reform Act was implemented. And this was one of the first pieces of legislation that addressed the guidelines and recommendations for improving the quality of care in the nursing home setting. In 2006, CDC published the healthcare policy. Excuse me one moment, I'm having some difficulties with this PowerPoint. Give me 1 second, okay? Okay, are you able to, I'm sorry, Raj, are you able to see my slide progress?
Yes.
Okay, all right, apologies. Moving forward, so this one is not cooperating for me, but I will just wing it and move forward through it. So in 2006, CDC's HICPAC published the management of MDROs in healthcare settings. So this set the precedence for how and what should be done in nursing homes and long-term care settings with the management of multi-drug resistant organisms. And then shortly after, in 2007, the guideline was put out for isolation precautions, so preventing transmission of infectious agents in healthcare settings. So these two documents helped forge our way to where we are and before the pandemic. And then in 2014, the World Health Organization established the Infection Prevention and Control of Epidemic and Pandemic-Prone Acute Respiratory Infections in Healthcare. So you may ask, why am I going so far back in time? I just wanted to reiterate that most of the tools that we need to combat a lot of our IPC lapses and challenges have already been put into place. But as you see here on this slide, most of the nursing homes that were looked at recently by a government agency, they looked at deficiencies that occurred by state survey agencies between 2013 and 2017. And so most nursing homes were cited for infection prevention and control deficiencies at 82%. And infection prevention and control deficiencies were the most common type of deficiency cited in surveyed nursing homes. So we still have a long way to go. So now I want to pivot to go into the first year of the pandemic. Most of you are all too familiar with what this timeline looks like. In January of 2020, CDC received the first reported case of COVID-19 in the United States. And then in February, even before the pandemic had been announced or there were multitudes of COVID-19 throughout our facilities, many of my colleagues were already receiving reports of PPE shortages. And this was the same month that COVID-19 was reported in the Washington nursing home. In March of 2020, it was declared a global pandemic. And then the toll quickly took hold of our country. And by May, 100,000 COVID-19 deaths were reported in the US. In August of 2020, COVID-19 was established as now the third leading cause of death. And then we jumped to December 2020, and the ACIP recommended long-term care facility residents and staff to receive the COVID-19 vaccination. So what did we learn from the first detected outbreaks? One, healthcare personnel. Many worked while symptomatic with illness. Many also worked in multiple facilities, and many were not familiar with the recommendations for transmission-based precautions or the appropriate use of personal protective equipment. This was not at all their fault. There were many other factors that played a part in this, including socioeconomic, supply and demand issues, but each of these contributed to transmission throughout our facilities. And also long-term care facilities didn't have the sufficient access to the tools that they needed to follow the basic infection prevention and control practices that we recommend. So now we're going to go into during the pandemic to now. So in April of 2021, CDC revised their visitation guidance. And then in June, we recommended the nursing home COVID-19 vaccine reporting. In September of last year, we rolled out an initiative to try and improve our healthcare provider vaccinations in nursing homes, because at that time, if you remember, many of the nursing homes had less than 50% of healthcare providers vaccinated. By October 2021, CDC recommended the COVID-19 booster. And in November 2021 is when we saw a large spike in COVID-19 cases throughout the country. And the World Health Organization classified Omicron as a variant of concern. And then the most recent, in March of this year, a second booster was recommended for older and immunocompromised. So some of the common infection prevention and control gaps that we've seen throughout the pandemic, one pertinent area is hand hygiene, which we know hand hygiene has always been a challenge for many healthcare facilities, not only nursing homes, but hospitals and other long-term care settings. It's a poor adherence to hand hygiene, limited access to alcohol-based hand sanitizer, and an ongoing idea of myths being truths when it's related to hand hygiene. So for instance, one that we still hear, even though there's been a strong educational component to it, is that soap and water is preferred over alcohol-based hand sanitizer, as well as the Life Care Code of limitations in how much alcohol-based hand sanitizer you can have in your facility. Neither of these are true, and neither of them are part of the CDC recommendations. In most instances, alcohol-based hand sanitizer is recommended to be used by healthcare personnel, as well as, although there are limitations in how much you can have in your facility, it does not limit the number of access points that you can have the alcohol-based hand sanitizer. For precautions and PPE, before the pandemic, we saw a lot of areas that didn't use transmission-based precautions. And there was a lack of preparation to use and handle these. So not only were there many facilities prior to the pandemic that didn't know how to use it, they also weren't really sure where it was kept. So we saw facilities that kept it in a utility closet because they didn't use it. Or they had received education 5 years ago when they had one person that needed to have contact precautions. Because if you think in the last 5 to 10 years, nursing homes have morphed into these subacute facilities with very sick patients. And so they had to prepare to use these inside a pandemic. We also saw a lot of staff competency checks that were lapsing. So they didn't have the staff to be able to show people how to appropriately use IPC practices. They didn't have people or time to say, this is how you don and doff. And so there were many lapses that continued for that. We also saw that ongoing lacks in communication between healthcare facilities was still occurring. And we know this is a problem, but it was even exacerbated more by the COVID-19 pandemic. As well as environmental cleaning and disinfection. And I put on here an EPA registered disinfectant because there were some that we have seen in recent deployments where facilities are still using a product that only has claims against COVID-19, but they don't have claims against other NDROs, or they have very, very long dwell or contact times. And so even if the staff is using appropriate practices for performing environmental cleaning and disinfection, they're not always getting those dirty bugs off of the environment because they're either not using the right product or they're not allowing it to stay wet long enough to kill. Also, a lack of access to cleaning supplies. There have been some facilities that we have visited that only have one closet to receive cleaning supplies, and this is a 150-bed facility. And so what we have found is that if staff don't have access to it, they're less likely to use it. And then staffing, training, and education. We have continued to hear of many, many facilities that have an infection preventionist, but then they're also the DON, or they're also the ADON, or they're a staff nurse filling in the role shortly and briefly. Or we've had new infection preventionists that are just getting into the role. Many have not had dedicated infection prevention and control time. They've not been able to provide appropriate training and education. And then they have also had to take on additional roles on top of having to provide their primary role. So along with all of these gaps and challenges that we've seen, we also understand that COVID-19 has exacerbated the staffing challenges. And as you can see on this graph to the right, you can see from May 2020 to March 22, how much this has been exacerbated. 28% as of March, 28% of our nursing facilities were reporting to NHSN that they had at least one staffing shortage. And many of those reported that that was a shortage of their certified nursing assistants. This is also exacerbated by low resident census, so not as many staff are needed in the facility, but then when census goes up, they can't find the staff necessary to safely care for their residents. And then low staff morale. We have seen it, heard it, felt it, the burnout and fear, the fatigue, the negative public messaging, and it's causing a lot of staff members to leave the bedside altogether and not want to come back. So consequences of the staff turnover and the shortages. We haven't been able to provide and sustain training. So we haven't been able to teach those best practices and sustain them because of the high turnover. There's been ongoing increases in resident to staff ratios, as well as use of agency staff. Some facilities that we've recently talked to are upwards of 75 and 80% of contract staff being used. And this causes a challenge because those staff members are not familiar with the residents, nor are they familiar with the facility policies and procedures. There's a need for staff to take on additional duties, such as asking a staff nurse to begin doing your COVID-19 testing, or having the respiratory therapist to bag all of the COVID-19 tests to send them over, or even having staff members take on additional environmental cleaning and disinfection duties. And then again, the impact on the remaining staff members' resilience and morale when they see all of the significant staff turnover. So why are long-term care facilities so susceptible to infectious disease outbreaks? Well, as you can see here, and many of you are aware, this is a congregate setting, and many of our facilities have shared rooms. A majority have two residents to one room, and may have up to 4 people sharing a bathroom. But there are still some settings that have upwards of 8 sharing one physical space together as a resident room. There's limitations to the built environment. Many of our nursing homes are grandfathered in for policies and procedures. And so they've not been required to make updates to the built environment of their facilities. Most of these are older, or they were converted to being used as a long-term care facility when they may have previously been a school. Our population is at high risk for multiple adverse outcomes because of comorbid conditions, previous hospitalizations, and then our long-term care residents have very long lengths of stay. So what have we learned? One of the things that we have learned is that communication and coordination with public health is essential. We have a critical role to share in this communication with our partners. You are pertinent to this ongoing communication, as well as our state, local health departments. These include those that provide immunization services, our state survey agencies, the epidemiology experts that are available to assist you, as well as healthcare associated infections and antibiotic resistance prevention. Our QIOs, which I'm hoping that a majority of you are familiar with and have utilized their services. We also have academic partners that many of our facilities partner with to improve our residents' outcomes. and state-affiliated long-term care provider organizations. So AHCA and INCAL, the American Healthcare Association, Leading Age, AMDA. So our continued partnerships are essential. The supports you can see here on this slide are limited not only to these that are shown, but a wide array, including provision of IPC guidance and technical assistance whenever you have an outbreak occurring, maintaining that ongoing communication, not only with the nursing homes, as well as the hospitals, assisted living facilities, and community partners. They can also help work with you for problem solving and sharing the best practices or the most up-to-date guidance that is available. Vaccine coordination, which is essential today, and promotion, and then coordination. The second is that facilities are creative and resourceful. Many of our staff have gone above and beyond to take care of their residents. They have worked extra or longer shifts. They've adapted to the ongoing changing guidance and PPE recommendations. Many have slept at their center during an outbreak just to protect their family and loved ones. They've learned how to provide monoclonal antibody. They've also taught residents how to use technology like iPads to stay in touch with their family and friends. They've provided residents with social supports. Third is vaccination is a very powerful tool. So as you can see on this slide, it's protected residents and staff. So in the top left corner, you can see the confirmed cases and rate per 1,000 resident weeks in residents by week. So this goes from July 2020 to July of 2022. In the blue arrow, that was when our initial vaccination rollout occurred. And then in July of 2021 is when the booster rollout occurred. So you can kind of see that high peak in January. That's when Omicron kind of took hold of our country. In the bottom left corner is the confirmed deaths. So as you can see, from the initial vaccination rollout peak to January of 2022, the deaths significantly declined. So when you look to the right, this is for the staff and skilled nursing facilities. And as you can see, although it is not as significant of a change, the deaths have definitely decreased as well. So increasing staff COVID-19 vaccination does protect our residents. So this is a little bit of a busy slide, but I'm going to try and walk you through it. So on the left-hand side, in A, column A, you have counties with a high prevalence of COVID-19 resident cases. In column B, these are counties with a low prevalence of COVID-19. So this is looking at June 13th, 2021 to August 22nd, 2021. So this was before Omicron, but when we had a significant rise. So the red column is for facilities with a low rate of staff vaccination. The blue line, the lighter blue line, the dashed line, is facilities with a high rate of staff vaccination. So if you look at the differences, you can see that those facilities that had a low rate of staff vaccination had significantly more cases than those facilities with a high rate of staff vaccination. So this is just a slide to show the rates of lab-confirmed COVID-19 hospitalizations by vaccine status. One of the reasons that we wanted to share this slide was for the top information. So as you can see, for a majority of our residents and staff, it would be the last three boxes. So hospitalizations were 2.7 times higher in unvaccinated adults, ages 18 to 49. 3.4 times higher in unvaccinated adults ages 50 to 64, and then 3.8 times higher in unvaccinated adults ages 65 and older. So as you can see on the graph, the green line represents unvaccinated, the blue line represents the primary series, and then the blue dotted dashed line represent the primary series plus 1 or greater boosters. So you can see a significant difference even in hospitalizations from becoming vaccinated. And then the fourth, we cannot forget about recommended infection prevention and control. So where do we go from here? And Raj, was Bola able to join? Perfect. I'm going to turn it over to Bola now.
All right, sorry, apologize for the technical difficulties earlier, but I was also looking at your polling results. So it's awesome to be here, and it's equally awesome to get the results that you guys have answered, like the questions that we put for the polling. So welcome everybody, and really great work, and kudos to you all, every single one of you, for being here and for trying your best to bring out the best out of your residents as well as your facilities and yourselves too at this difficult time. So I always like to start out with an appreciation of everything that we have accomplished over the last couple of years. We know that it's been insane is an understatement, but thank you and kudos again, as Heather illustrated earlier, for just being there and for doing the best that you have. Continue to do even now. So we want to give kudos to everything that's been accomplished. We appreciate the fact that our COVID case and vaccine data that's captured with our NHSN reporting system is at least robust now, which is really commendable, which we had not had prior to COVID with the usual reporting. So we're deeply thankful for that. We also have been able to have our health departments scale up their outbreak response capabilities, as well as incorporating lab testing and also point of care testing throughout different facilities within jurisdiction. So we're deeply grateful for that. The other thing that I think we are also seeing a lot of facilities get used to cohorting residents and staff on a facility-wide scale, probably more than they've done from way back, essentially. The other thing that I think we've been able to capture is our facilities are also monitoring their residents as well as staff for illness and exposures. And so overall, we thank you guys again so much for really adapting to changes in testing, as well as our infection prevention and control guidelines, and really understanding what you need to do to implement infection prevention and control strategies to prevent COVID-19 from entering the facility, and if it already is there, from preventing it from being transmitted to all the residents as well as staff at your facilities. The only other thing that I think that we've seen a lot of has been education. And I think on the polling question, some of you had indicated that there are still needs for infection prevention and control training. And so we hear you. And again, we have a lot of resources that are available on our website. Please, you are welcome to reach out to either one of us or just to the CDC at any point in time if you need more training materials for your facilities. So overall, we are glad that we have the infection prevention and control infrastructure as well as support. And really, we're glad to see you, every single one of you, working on the front lines in your different programs. We recognize that there's still some work to be done, but we at least acknowledge every single thing that every single one of you have been doing the last couple of years. And so, and I say this because we recognize even more so than ever the need to continue to prioritize infection preventionist role. And I think Deb Birdsall was going over the CMS timeline earlier, and it really highlights, CMS's interest in protecting the time needed for infection prevention and control duties, which is great. We're glad that it's part of the regulation now. And then we also realize that there are, like I mentioned earlier, there are a lot of training opportunities that some of you have voiced there's a need for. So again, we encourage you to continue to reach out to us if you need more materials. But overall, the IPs need to continue to be empowered with the training resources are really above and beyond anything that we've ever needed over the last couple of decades. So we thank you so much for reaching out and collaborating with your different partners, even if it's your neighboring hospitals that you're collaborating with, or your Quinn or QIO, as Heather mentioned earlier. That's a great partner to really reach out to, as well as your health department and the CDC as needed. So we'll go to the next. So we did talk earlier about surveillance data being directed to target action for infection prevention and control, really strategy implementation. We recognize that a lot of facilities have reached out to public health as well as other partner support. And we've had instances where we've had some Quinn, QIOs reach out to facilities to get them enrolled in NHSN and such, essentially. So we thank you guys for doing that. NHSN really has transformed how nursing homes conduct surveillance for infections as well as outbreaks. So this little the little graph, like on the right hand side, just tells us what we've seen with COVID nursing home data reporting. So as you can see, we recognize again that we do have the resident data information like reported even more so now than it's ever been, as I illustrated earlier, which is great because then we can capture really what's going on with COVID as much as possible in terms of vaccination with COVID, in terms of illnesses. We can capture that with the NHSN data, which is great. If there are any facilities that are still having challenges with reporting to NHSN, please feel free to reach out to us because we can help you through that process to navigate the best way to do the reporting. So next up, we do also want to continue to work on supporting resources, like I mentioned earlier, for our frontline staff. Some part of that could be maybe having a frontline staff like express like their fears as well as concerns. We're sorry we didn't put that as a poll question, but you did indicate the challenge really. So we had, I think it was the first poll question or the fourth one, where we asked you guys to indicate your greatest challenge right now related to COVID. And I think overwhelmingly a lot of respondents ended up referencing like staffing as one of the biggest challenges. And so we recognize that. And if there are any strategies that you think we can help you out with, again, please feel free to reach out to us. So talking about staffing though, we did recognize that, even at the beginning of COVID, that not a lot of facilities necessarily have like flexible leave policies. And so we have continued to encourage facilities to not have punitive actions for their staff taking out time when they're sick, because you don't want staff to be working sick. And I think also a lot of the facilities had provided like counseling services, even in the middle of COVID and the mortality cases that happened right in the middle of COVID. So that was really encouraging to see. And again, if you need such resources or links to resources, we might be able to identify states that are doing those, that are making those services available, so that that would be available for you guys to reach out to. So next, again, we want to remain vigilant for COVID and beyond, because we still have ongoing outbreaks, even now, with other diseases. So we cannot forget, again, the basics, which I'll go into in a few minutes. So some of the examples of some of the ongoing outbreaks that, again, that stress the need to continue to focus on basic infection prevention and control practices have been investigations for invasive group-A strep, as well as your carbapenem-resistant Enterobacteriaceae, and C. aureus, which a lot of you have heard about, and then norovirus, and many more organisms. And I think, I can't remember if it was Wimla or Morgan that went over the emerging resistant pathogens. And so we have a lot more organisms to worry about. But again, we have to keep the basic infection prevention and control practices really, I think, like, we have to stay adherent to basic infection prevention and control practices, and we have to remember that those need to be in place at different facilities. So we'll go to the next. So the first one, as I was illustrating earlier, is just the program as well, and infrastructure. So, and we know that CMS already has this outlined, like in their regs. So have a written facility risk assessment that's based on your resident population, as well as infection prevention and control plans for emergency preparedness, including pandemic, as well as natural disasters or flooding, or any disasters that can happen in any minute. And then have your facility have written infection prevention and control plans, and processes, right, for reviewing those surveillance activities, where you will need to have an annual review, done, and reassessed every single year. So if your resident population changes, then that annual review needs to be redone, essentially. And then the other critical thing is to continue to train our infection prevention and control personnel, so our IP personnel, and to carve out dedicated time for the program. I think, as illustrated like earlier, we have interacted with facilities that have, for instance, the IP also serving as DON, the discharge planner, as well as the wound care nurse, like 3 different 4 hats at the same time. So we understand that it's almost impossible to carve out protected time in that instance. So again, we continue to reiterate the need to have that trained IP as well as protected time for that IP. Next up, we have hand hygiene, which is one of the basic fundamental components. I think we have reiterated at least a couple of times that CDC recommends the use of alcohol-based hand sanitizers, essentially as a primary method of hand hygiene in most healthcare situations. And the other part of that is to also ensure that your facilities have access, just like you guys have really done well having PPE access during COVID. We are really reiterating the need to have continued access to PPE, as well as hand hygiene supplies at the resident's point of care. So ideally in each resident room, or every couple of rooms, but having it accessible to the healthcare personnel as they're doing their different resident care activities. So again, we went over staffing as well as training and education, and then interfacility communication. We have seen that consistent interfacility communication is great, not just for the receiving facility, but also for the transferring facility. So that we've had a number of facilities partner with their neighboring facilities so that they can get that information interchanged pretty regularly, and so they know they have that level of awareness about what's going on at the neighboring facility, which is amazing. And some of the facilities have also involved their health departments in trying to come up with strategies for this interfacility communication. And we do have examples that are outlined, like the CDC interfacility communication tool in our resources. Next up, again, we have resident safety. So again, continuing to promote resident safety vaccination as well as documentation. So I, recall in nursing home, we were told if it's not written, if it's not documented, it wasn't done, essentially. So again, we recognize really everybody's help with getting our residents vaccinated, but we want to continue to encourage you to document their vaccination records with COVID, pneumonia, as well as influenza or any other vaccines that they get at the facility or they get before they get to the facility. Make sure everybody has the records in place. So another part is just educating residents on basic infection prevention and control practices. So whether it's with hand hygiene, before they eat, after they use the bathroom, that sort of thing, and also reducing clutter. And the other measure of accountability with healthcare personnel would be healthcare personnel informing the resident of what they're about to do so that it's basically a transparent form of communication. So for instance, if someone's getting ready to use the resident's Hoya lift to get them up or to sit them up in the chair, the healthcare personnel would be expected to say, hey, Miss Bola, I'm going to put you up in the chair using the lift, and I will clean the lift after I'm done, and so the resident can then hold us accountable at the point of care, essentially. So next up, we again have a healthcare personnel safety. So I talked about that earlier with work exclusion policies, so that there is no punitive action being taken for staff calling out sick. And also, we're encouraging facilities to have a process for encouraging prompt reporting of signs and symptoms of a potentially transmissible illness. I think one of the things that we noted earlier on with different outbreaks is that there were periods of time where the staff would be homesick and may not necessarily think to call the facility to give the facility a heads up. So again, there has to be that level of transparency between the healthcare personnel and the facility so that they know if they're not feeling sick, even though they're not scheduled to work till next week, they let people know at the facility just as a heads up. And then another thing is just vaccinations. Again, we've captured that with our NHSN, just continuing to have facilities encourage our healthcare personnel to get vaccinated, as well as our residents. And then the bloodborne pathogen exposure control plan by OSHA, it's nothing new. It's been existent for a good while now. There is also the need to have ongoing competency-based training and education for staff. So it's not just a set of PowerPoint, but having staff do return demonstration of what they learned about. So if you're teaching staff about wearing PPE, have staff demonstrate that they know, what order or what sequence to wear their PPE and what needs to be done once they're done, for instance, with doffing their PPE. And so the other part of that is just to have facilities have ongoing audit and feedback for staff adherence to policies. We noticed that some facilities, I think at the beginning, didn't necessarily have that process in place. And so I think over time, a lot of facilities started having like that rolling process in place so that they would even have their, like off shift covered. So they would have weekend staff getting audited and feedback being provided to staff during their shift, which was always nice to see. All right, next up, again, I think we talked about surveillance earlier, but I'll just highlight a couple things for here. So it is, again, remains critical um, to have that surveillance done and looking for different presenting symptoms or signs and symptoms at the point of the resident's admission into the facility. And then there should be a process or procedures to identify potentially infectious residents, as well as even on admission and during their stay, essentially. So have the facility have a system for notifying, like for instance, when they have a potentially infectious disease at the facility, or even before getting admitted to the facility. And then also a system for notification when antibiotic resistant organisms are reported by the lab. And we did talk earlier about interfacility communication. Again, I cannot stress enough how critical that has been, even more so now. And next up, we have disease reporting. So again, we have found out how critical it is to have facilities have a very well written outbreak response plan that outlines the definition as well as procedures for surveillance and containment, as well as list of pathogens for which monitoring is performed, as well as the current list of diseases that are reportable to public health. And then one thing we also found out is that the point of contact earlier on, this is pre-pandemic, that the point of contact at the local or state health department was not necessarily available to all staff at facilities. So that I think has gotten tremendously better, and we are truly thankful for facilities really having that process, and really also thankful for collaborations that have evolved between facilities and their different health departments. So that's amazing. Next up, again, is hand hygiene, which I covered earlier. So we'll go on to proper selection as well as proper use of PPE. So facilities should have procedures for standard precautions. And one other thing, and I think we put this link in the resources. So the enhanced barrier precautions for nursing homes, it just posted on our website today. So this is only specific for nursing home settings. We have a link to our frequently asked questions that are included in that resource list, as well as any other information that you guys might have even after this webinar. So bottom line, again, it's specifically for nursing home settings. The other thing is the rationale behind the enhanced barrier precautions is to have healthcare personnel wear their gown and glove when they're taking care of residents with high risk, or what we call high risk residents, essentially. So it would include residents that have rooms, as well as residents that are, for instance, like they come in, sorry, so residents that have rooms as well as residents that have devices. So devices, any invasive devices during their care of those residents, essentially. So it does enhanced barrier precautions does not necessitate room restrictions. So if you have someone on enhanced barrier precautions, they would not have to be like in a separate room or in a different room. Could just be in their room, but then the person taking care of them would have to wear gown and glove when they're doing those specific activities. Again, the high risk, high contact, high touch activities with the residents. And some of those high risk activities include like dressing, bathing, showering, providing hand hygiene, as well as changing bed linens or changing grease or assisting with toileting. And then again, like device care. So any kind of device care, like for instance, with central lines, Foley catheters, feeding tubes, tracheostomy or ventilators, they would need to wear their gown and glove. And then also very critical is to have healthcare personnel wear gown and glove whenever they're changing dressing for like any wounds. So if anybody is getting wound care, they would need to have their healthcare personnel like wearing the PPE, the gown and glove, essentially. So, yeah, so that's sorry, the long and short of the enhanced barrier precautions that just rolled out today. So again, more information is available on that resource link that we are sharing with you guys. And so I don't have a lot more time, so I'm going to try to wrap it up as much as possible. So again, had talked about PPE as well as hand hygiene supplies being readily accessible, which is critical and remains critical even now. And then we'll just go on to like the respiratory hygiene and cough etiquette. So have your signs. You guys know this CDC sign has been here for a number of about 15 years now. So please feel free. It's free. You guys can print out the copy and put it at your different locations at your facilities. And then the next up I have is core elements of antibiotic stewardship. So again, I think Melinda went over this earlier, and I think Dr. Rinwa went over this earlier as well. So I won't belabor the point. I'll just talk a little bit more about injection safety and the point of care testing. So we are again reiterating consistent facility like adherence to injection safety. Believe it or not, there are still outbreak investigations around injection safety at this point. So again, whether it's finger sticks or point of care testing, just cleaning and disinfecting with an EPA registered disinfectant before it's used on other residents at the facility. And then environmental cleaning and disinfection. I think Heather got into this earlier. And so I think at this point we'll just pause because I realized that I talked a lot. So I will just pause and just wait for you guys if you have questions.
Well, thank you, Heather and Bola. That was just delightful. Thank you so much again for taking time. I know you're all so busy out there with everything that's happening, and again, thanks to Dr. Jacob Slivka for the introduction. We have a few questions, kind of technical here. So if you could answer to best of your ability here. So one of our medical directors, actually local health department, Dr. Chug, asked if there are any suggested online resources for LDCF employers and staff to help boost the staff wellness, resilience, and retention.
Yes, there are some of our state departments of health have available, and we didn't want to show preference to a specific
Yeah.
state, but if you can email me, I can definitely share those with you. There are a few really, really good resources out there.
Thank you. That'd be very helpful. I'll definitely if Dr. Chug, you want to CC me as well on that email, and I know there will be more participants interested in that. Then we have another question. It's kind of technical question. Is there a limit on how much hand sanitizer they can have in the building for the life safety code here in Illinois?
Yeah.
So go ahead, Bola.
Oh, so our hand hygiene page actually has a link, and we can share that, or I can share it on this to
I
like the
believe
capacity.
we shared it in our resources.
Yeah. So it's part of our hand hygiene. I think it's called Fire Safety and Hand Sanitizers. It's on the CDC website. Fire safety considerations, I think, for hand sanitizers is what it is. And I will share it right here. I'm going to share the link right here.
Yeah, and it is overall it's 10 gallons. I don't know if there's state-specific guidelines that oversee it, but federal is 10.
Okay, thank you very much. And we have a comment and a question here by Leanne Walls. Is it really a number game when it comes to infection prevention requirement based on the number of skilled beds? Shouldn't the infection control program and antibiotic stewardship apply to all residents, not just skilled residents? So, for example, assisted living, memory care, etc. Maybe not all Illinois residents. Maybe not all Illinois resident. So this person, Leanne, says she has to cover both facilities based on number of skilled beds part of time, and so but the facilities are much bigger in the number of skilled beds that the skilled beds can reflect. So I think the question is the requirement, should that be based on total number of residents versus skilled residents only?
So right now there is no like regulatory stipulation, right, on the number per like however many residents they are at the facility. I think that I don't know if that's something that can be foreseen as part of maybe regulatory. I recall even, I think earlier, the CMS RFP had initially had something like, given that example of 100 residents, like 1 per 100 residents, right? And so that's not part of the final language right now, but I don't know if that's going to be a future stipulation in terms of the regulation regarding that.
Thank you for that. Sorry, go ahead.
I was just going to speak briefly on the assisted living and memory care. So we're starting to do some work in the long-term care division with our team specifically looking at other settings other than skilled nursing facilities and assisted living. And I do know that AMDA is starting some work as well in assisted living, just to look further at what we should be looking at for recommendations and how to best support them for their IPC practices.
Thank you. Thank you very much. I think we're past time here. We do have a couple more questions here that we didn't get to, but I just quickly want to last question, if you can just very quickly just comment on enhanced barrier precautions. And so once we address that, we'll hop on to the next final session. Shannon, you're here. Are you here with the whip?
Yeah, that's fine. You guys can go all the way till 6 if you want.
You don't get CDC every day, so we were trying to extract
you
as
guys
much use as we
Go
can.
on as long as you
You're
need.
more than welcome. Sorry.
No, you.
Yeah, happy to stay on if
Yes.
they want to stay on. We can continue
Absolutely.
answering questions.
I will email out all CE information so everyone in
Okay,
this session, don't worry, you're not missing out on anything. So feel free to
Okay.
keep the conversation.
So how long can we stay? Now, when is the wrap-up session start?
The
Shannon?
wrap-up session is starting, but that's just for CE information, and this
Okay.
platform is open till 6.
Oh,
So
okay.
you've got
Absolutely.
at
Thank you.
least
So
an
if you
hour.
want to go ahead, so we have a couple more questions. So you
Okay.
know, I'm
Go for it.
happy that this is important. So
Okay.
so enhanced barrier question on that. So if you guys just comment on that.
So yes, Leanne. So that is part of. So we just actually made live today our
Mhm.
updated guidance for enhanced barrier precautions. And what the new recommendation is that it is for any resident with an indwelling medical device or any resident with a wound that requires a dressing. So not just a skin tear that has a Band-Aid, but an actual wound that has wound practices being performed on them. It also applies to the entire facility. And as well as, sorry, those are the changes that have occurred. So what stays the same from the previous guidance is that it's any, as well as any resident with a known MVRO infection or colonization. Part of the reason for the updated guidance is that we have seen multiple studies and publications that show us, especially in our nursing homes, that we don't know who actually is colonized with an MDRO. So this practice is not only better to help reduce those transmissions, but it also is going to help lessen the burden of isolation for our residents, because they're only going to need to have the staff member to wear gloves and gowns when they're performing high contact resident care. And the resident is not going to be limited to the room. So they can still participate in all the group activities and all of the, go to the common areas that they like to visit.
Thank you very much. And so one last question I will take again, Leanne. We really appreciate you asking all these important questions, very practical. And so another question Leanne asked is, can we get a sorry guys for that. Can we get a very clear requirement for sharp containers in at least skilled resident rooms too? Please, we are told no because it interferes with home-like environment.
So I think that would be.
Oh, sorry.
Go ahead, Bola.
I think that would be. So I'm looking at the newest regs, right? The updated regs. It doesn't specifically state, that sharps containers have to be like in the skilled residence rooms, even though we recognize that injection safety activities are going on in the residence room, right? It does say that staff needs to have access to those sharp containers. So I think, we could definitely take the feedback back to CMS to see if, that's a consideration that they might be willing to look at to specifically say it needs to be in this. But I think even historically, it hasn't said, it just says it needs to be accessible, just like OSHA just says it needs to be accessible, but OSHA doesn't say it needs to be in the bathroom or, in the residence room specifically.
So thank you very much, Heather and Bola. Thank you for staying a little longer. And again, thank you everybody for attending this. We might get the tail end of our wrap-up session. And again, congratulations to everybody for staying on and for this wonderful day today. I think there was a lot of learning. Again, meet you everyone next year, hopefully in person. And thank you, CDC, for. So here we have the famous Jamie Jacob is here. Do you want to do some final words here in our group? We were having a very robust discussion ongoing here. Yeah.
I was just going to say Shannon did finish up the closing remarks in the other session, so not to head over there. But thank you all, everyone in this group. It looks like it was a very popular session. Thank you for joining today. Hope you all learned so much. Shannon will send out a mass email to all attendees regarding CEUs.
All right, for anyone that just joined, just again, thank you all so much for being here and joining us with this summit. Apologize for any technical difficulties we may have had,
I think we have.
but also,
Thank you, everyone.
Thank you.